Well, all right. I hope everybody can hear me just fine. As you know, my name is John Rivera. I've been involved in auto transfusion for almost 40 years, as well as blood banking, and I do speak at a variety of perfusion schools. And I'm a member of the International Board of Blood Management and the item submitter for both the PBMT and PBMS tests. I want to thank Mohammed and Sherry for this invitation. It's truly an honor to participate in this meeting, and I look forward to your questions and anything else that anybody might have to say. I have no disclosures. I retired from Medtronic in October of 2020. I had served as a consultant for them until February of this year. I'm currently in no physical or financial relationship with any company. This presentation, you'll note that is using a Medtronic background. It's a presentation that I've used in portions previously, and I expanded upon it directly. And of course, we're going to talk about the incremental use of autotransfusion. When we're done talking, you're going to be able to understand maybe a little bit better where autotransfusion is indicated. Hopefully, you'll understand that autotransfusion is very cost effective. I intend to teach you how this is an incremental process. It's not an all or nothing process. And to assure you that red blood cells that we recover via autotransfusion, not only are they safe, they're literally the very best red cells that you can be giving your patients. And of course, autotransfusion is one of the key modalities per the STS-SCA blood conservation guidelines, and I will talk about that later. Of course, everybody knows what autotransfusion is. It's just simply trying to get the patient's blood back to them. However, what people do not realize, it doesn't always involve a cell salvage device, centrifugal separation capability, that there are also direct reinfusion systems where the blood is collected into a reservoir with anticoagulant. And after adequate blood has been collected, the reservoir is inverted and that blood is being given back directly to the patient. I will talk primarily about centrifugal cell separation, but I will be touching on direct reinfusion. And I am sure that our esteemed colleague and friend, Bob Groom, will have much more to say about that. He's truly an expert in this arena, and he is working in Africa. And don't forget, Bob Groom is truly one of the heroes of perfusion. So people will ask first, okay, John, when should we consider autotransfusion? Well, interestingly enough, there's going to be kind of a theme here. What we're looking for is a patient in a surgery where we anticipate that up to 20% of their blood may be lost during the procedure. We know that physicians routinely order cross-matching of 2 units of packed red cells in the blood bank. And remember, a whole unit of blood is 500 ml, so that's also about 1,000 cc's. They're also looking at when the average transfusion volume is 2 units of blood. We do have patients with rare blood types. If it is an urgent scenario and we do not have that rare blood type immediately available in the hospital, then we have absolutely no choice but perform autotransfusion. Well, of course, in cardiac surgery, it's one of several surgeries where 20% or greater of the patients are being transfused. And with blood management programs, they are dropping that participation in receiving allogeneic blood. Of course, Jehovah's Witnesses are one unique group of individuals who absolutely do not accept allogeneic transfusion from the blood bank, but will accept autotransfusion. And even though it's been validated and published in both of their key periodicals, Watchtower and Awake, it's still up to the individual witness, and you have to have that conversation. Of course, perfusionists, you're involved in cardiac surgery, but oftentimes you are also performing autotransfusion procedures for the other surgical specialties in the hospital, such as ortho, neuro, OB-GYN, urology, vascular, spine, and of course, trauma. Well, not giving the patient donor blood actually has both a clinical benefit and a financial benefit. If we don't give the patient donor blood, we're not going to transmit any level of disease. So we're giving back the patient their own blood. They can't make themselves sick. Of course, We also, since they're getting their own blood, they're not going to have a severe transfusion reaction because they were previously transfused. And it helps us conserve valuable allogeneic blood supplies for other patients where autotransfusion is not indicated or when we have to combine both therapies. Financially speaking, blood is expensive. I'll talk a little bit more about that. And as we know, when a patient has a complication or they are returned to the hospital, that could involve additional transfusion. And as you understand implicitly, if a patient comes back to the hospital due to a non-event, and transfusion reaction is one of those non-events, it is up to the hospital to absorb those entire costs, and they could be fined by CMS up to $100,000. So that's a tremendous financial incentive not to give blood to the patients. To this very minute, the primary cause of injury and death during allogeneic transfusion are clerical errors. So even though the computer's involved, even though it's triple checked, it is still happening a few times a year. Well, we are going to talk about, and we understand that there are three key factors here: blood shortages, not enough blood to go around; patient safety. If we don't transfuse a patient, it will certainly elevate the safety of the event. And in a minute, we're going to talk about how expensive blood is. And of course, adverse reactions, increased length of stay. And remember, the DRG does not pay us extra if we're going to be in the ICU for extra time or in the hospital for extra time, or we have to treat a severe ongoing morbidity and mortality. Well, before the pandemic in March of 2020, we always assumed that we would have enough blood, but in reality, only 4% of the population was donating the blood for the other 96%. As an aside, I started my career as a sales representative for Terumo selling blood collection bags. And I'm actually married to an MT ASCP SBB, that's a specialist in blood bank from Hopkins, who is a director of technical services at two major blood centers. One is Miller Memorial Blood Center in Bethlehem, Pennsylvania. The other was Bonfils Blood Center in Denver, Colorado. And she was a director of transfusion services at Cedars-Sinai and was an AABB inspector. So a lot of what I'm talking about is not just because I read about it, it's because I lived the adventure. And of course, once the pandemic came into play, we didn't see 4% of the population donating blood. We saw that percentage to drop it to 3%. Even with the addition of the acceptance of blood from MSM, men having sex with men, we're not going to see an immediate increase. So I only see this issue being exacerbated and not getting better. Well, interestingly enough, AABB and their guidelines for blood recovery and reinfusion and surgery and trauma in 2010 made an interesting note. And that note is that when you look at the cost to cross-match 2 units of blood, and remember, I'm married to a blood banker who did that, the costs and time involved in that are exactly the same as setting up an autotransfusion collection reservoir with filter, adding an anticoagulant, and connecting it to a vacuum source. So to the dollar, they are equivalent. So like Dances with Wolves, it's a really good trade. So one thing we can do is save money and save time by teaching many people how to set up this standby collection system. And every operating room has a waste collection system that is very similar to an autotransfusion collection system. Of course, the difference in autotransfusion is that you have an approved large volume collection reservoir for blood with different levels of filtration. By the way, one of the things my wife pointed out to me that AABB did not point out, it takes about 30 minutes of the medical technologist's time to perform those 2 cross matches. If we give that time back to the hospital, that is at MedTech capability, that individual could support 2 to 3 other activities affecting 2 to 3 different patients in surgical situations. And that revenue opportunity could exceed an additional $2,000 to $3,000. Of course, if we have a patient coming in and we know they're going to be bleeding immediately, we can go ahead and set up the autotransfusion machine and disposable. But by using the standby system, we can set it up and we can wait and see, is there going to be enough blood to justify the procedure? And again, what is that value? Well, depending on the size of the patient, the sex of the patient, the type of surgery being performed, as little as 500 mLs of whole blood will clinically and financially justify the use of autotransfusion. Looking at the list, as we noted before, it's all the cases that we deal with, some of which are infrequent, others are on a daily basis. So what does a standby system look like? Well, this is what it looks like. What you're looking at is, you look at my cursor, is a bag of anticoagulant. In this case, it's ACD, that's citrate. You have the same 12-foot suction anticoagulant line, often called an ANA line, aspiration and anticoagulation line, a reservoir. And in this case, this reservoir is 4 liters in volume. They generally start at 2. And with the filter that's on there, that's a gross filter. I know it's 120, but the filters can be as gross as 180 microns, but as fine as 20 microns. 20-micron reservoirs are used primarily on surgery of brain tissue because brain tissue is so thromboplastic. It is almost too good of a reservoir for the rest of the surgical applications, so it is not a routine application. Now, I talked to, and I mentioned, let's look at the real cost of blood. And historically, as you look at all the papers, the mistake that was made is that they stopped at the acquisition cost from either the American Red Cross or Community Blood Center. And in reality, there's much more handling and cost involved. So Dr. Aryeh Shander, who is now working with Acumen as their medical director. Prior to this one, he was at Englewood Medical Center, which is the hospital, the main hospital in the world for performing surgery on Jehovah's Witnesses. He and other physicians, both at Rhode Island Hospital, that's Dr. Joseph Sweeney, as well as university medical centers in both Austria and Switzerland, did what was called activity-based costing. So if you will, imagine having a stopwatch and a video camera and following that unit of blood throughout the hospital, watching every step that's happening, timing what is happening, and figuring out the cost for that time, including the individuals manipulating that process. Well, in reality, what they identified was the true cost of blood is actually 3 to 5 times the acquisition cost. And what does that mean? It means that a packed cell will cost anywhere from $800 to $2,000 per packed cell to give to a patient. And I can assure you, half of autotransfusion in the US is by service providers, and about $800 is about the maximum charge. And then the other half is done in hospital. And again, depending on the individuals involved, that's about a $300 to $400 cost. But the point is, 1 unit of packed cells absolutely cost justifies the entire autotransfusion activity. And don't forget, this study is talking primarily about packed red cells, but the same is true for fresh frozen plasma and platelets and cryoprecipitate. So at the end of the day, not only do we not have enough blood, we're also assuming that the cost is low. In reality, the cost is high. So why are we there to perform autotransfusion? What are our primary goals? Well, we want to get the patient's red cells back to them. We want to get as many as possible and lose as little as possible, both to the waste bag and hemolysis. We want that product to be safe. We don't want to exacerbate bleeding by sending adverse materials like free plasma, hemoglobin, anticoagulant, activated cellular material, D-dimers, etc., fibrin degradation products. We don't want to give that to the patient. We want to minimize waste to the waste bag. We want to be efficient. If we do this well, we will recover at least 75% of what comes into the system. Why do we not recover 100%? Because of hemolysis, because of clotting, because of sponges, because of spillage. And unfortunately, in reality, in surgery, we are not going to recover 100% of the red cells. And of course, we want to do this as quickly as possible. To boil this down to one sentence, what are we? We're volume resuscitators, and we go as fast as needed according to the rate of blood loss. So patient bleeding quickly, we need to go fast and go into the trauma mode. Well, autotransfusion is a series of components, starting with a suction tip, a 12-foot bifurcated suction anticoagulant line, where we're not only sucking up the whole blood, we're adding anticoagulant simultaneously right at that suction tip, using either a citrate-based or a heparin anticoagulant solution, a filter collection reservoir, then the actual separation system, which could be a bowl or a ring on the device, and the entire tubing set using saline as a primary wash volume, and then passing off the wash blood in transfer bags where the air has been extracted. And that is highly encouraged by AABB. However, there are many, many locations that directly connect to the system. The holding bag for the wash red cells is clearly labeled, do not use a pressure cuff. And in reality, if they want to direct connect to the patient, it's easier to plug a transfer bag into the holding bag, let anesthesia connect to that transfer bag. That has many advantages for the addition of costs of $1.50. It extends the length of reach by 4 feet. So instead of 8 feet of reach, we now have 12 feet of reach. Anesthesia can raise it as high as they want to take advantage of hydrostatic pressure. The autotransfusionist can de-air the blood prior to transfusion. And lastly, the autotransfusionist always has eyes on the end product, because if that bag's behind the blue drape, we can't see if there are clots, hemolysis, or other evidence of adverse solutions or consequences. Well, I talked first about the standby setup. That is the first piece of the puzzle. Then what's going to happen is everybody in the operating room will be watching that reservoir, looking for an adequate amount of blood. Remember, I said that was between 500 mLs to a liter. In the case of contraindicated cases, it used to be absolute and are now relative: C-sections, contaminated trauma, cancer, and other infection states. I'm going to talk a little bit more about how we can use 2 reservoirs in a leukocyte filter to do that. Do not forget that if you have a patient with a decent hematocrit, we can perform acute normal volemic hemodilution of 2 whole units of blood, or 1 liter. And in that blood volume, besides having the equivalent of 2 packed cells, we have the equivalent of 3 to 4 units of FFP and a full 6 to 12 units of platelets in that product. So if the patient can tolerate that, that's a $20 15-minute activity that will benefit the patient. Because remember, autotransfusion only returns red cells and saline. If a patient has a significant blood loss of 50%, they're going to need coag factors. Thus, they need plasma. They're going to have a full body volume blood loss. They're going to need plasma and platelets. And we can drop the acute normal hemodilution blood from our system, connected already in a mechanism that will be accepted by the Jehovah's Witnesses. Now, the other part of the job of an autotransfusionist is to be a traffic cop. They have to watch what's going on at the table. They do not need to be looking down at the reservoir or the device. They need to look at the table, because there are many solutions and situations that are absolutely contraindicated, such as solutions like water, hydrogen peroxide, alcohol, hypotonic solutions that are going to immediately destroy the red cells. Now, I already mentioned about the relative contraindications, and I'll talk a little bit more about that next. And we will start with a 2 reservoir setup with 2 individual suction anticoagulant lines, each reservoir having its own bag of anticoagulant, and preferably you'd like 2 individual vacuum sources to do that. If you only have 1 vacuum source available, you're going to have to turn that vacuum source up to maximum, or the autotransfusionist literally has to watch which suction tip is up and which one is down. The one that's up, that's not actively collecting blood, we can clamp that right at the reservoir so that all the vacuum goes to the tip that is immersed into the wound. And of course, all of this is moot if we do not give it back through a leukocyte reduction filter. So cesarean sections, remember, even microscopic amounts of amniotic fluid can cause DIC. So we still, even though we're using both reservoirs, we still want to send frank amniotic fluid to the waste system, because there's going to be no blood there and the danger is tremendous. And using the 2 reservoirs, once we wash the blood with the best wash program on that particular device, all of that blood has to go through a leukocyte reduction filter. If we don't have the leukocyte reduction filter, then all of those adverse agents are going to go directly to the patient. Of course, when your local knife and gun club gets together this evening, and especially this holiday weekend, and commence to shoot each other, we pick those people up off the street. They've left an entire blood volume out in front of McDonald's. They arrive to our hospital. It's going to be a lower abdominal surgical intervention. As we know, we call that a code brown. Well, those are the patients that we could do the tandem reservoir with leukocyte filter. Historically, the issue with cancer, and especially the primary example was surgery for prostate cancer, was the ability to send cancer cells throughout the body, that is, inadvertently metastasize a localized cancer. And we absolutely do not want to do that. But again, using the two reservoirs, we can segregate the blood so that the potentially contaminated blood does go to that second reservoir. If we do get enough, once again, we're going to do our best wash and we're going to send it back through the leukocyte filter. Hemostatic agents, of which there are over 50 that you're currently using, their job is to stop bleeding and cause clots. And the last thing we want to do is suck those products into our reservoir because it's going to clot up your entire reservoir. As of this minute, the only direct hemostatic agent that I'm aware of that is completely labeled as being useful and safe during autotransfusion is a cellulose-based hemostatic agent called Surgicel. However, if you have any questions on the agents as well as devices and solutions being used during autotransfusion, look at that product insert that you threw away, because it's up to the manufacturer of that device, agent, or solution to have done the testing and to label the device as being cleared for autotransfusion applications. So I've already talked about using the two reservoirs with the two vacuums, but there are actually two ways to do this. One is side by side, where we're going to have the reservoirs on either a second holder on the machine or on an IV pole. But there's another mechanism where we can bring an IV pole, mount the second reservoir immediately above the primary reservoir. Now, don't forget, we're still using waste suction. And another thing to always remember is if the patient's bleeding that quick, especially a trauma patient, even though we're getting the blood in quickly through two front doors, that is those two collection systems, you're limited by the back door, and that is the device. So no matter how fast I get it in, I'm still limited by one device. So it would make sense to use two autotransfusion devices. And all of the devices have automated continue modes to do that. And they do not need the operator hovering over them. So now I could have up to 4 doors with 4 reservoirs coming into the house and 2 doors with 2 autotransfusion machines going out the back. So here is an example of a side-by-side configuration. There's a large specialized Y connector that connects between the two that already includes the normal step-down connector from the primary reservoir, and both of them are connected to the Bolin harness on the machine. And we're simply going to open and close clamps to move the reservoir, the blood from the second reservoir into the primary reservoir and into the machine. Now, that does involve that specialized Y. It does cost money. It may not always be available. An easier and faster way is in series. And in this case, this device has its own central IV pole. What you want to do is mount the second reservoir immediately above the primary, and you can see the step-down connector going directly to that second reservoir. There are 2 major advantages to doing it in series. Number 1, you do not have to have that special Y and you don't have to pay the money. And number 2, the blood gets filtered twice. When you do side by side, it ends up being bottom to bottom, and you consequently only get 1 filtration. Now, remember, in contraindications, even though it's indicated in the AABB guidelines, it is up to the autotransfusion team, the surgeon, the anesthesiologist, the personnel at the table, the autotransfusionist, and the lab to make the final decision. So it isn't just the decision of the surgeon to go ahead and perform the procedure. If you have a patient coming in and you know it's a trauma scenario, it's really important, even before the patient gets there, we're going to jump the gun and already have the machine or machines and disposables and reservoirs already mounted, because we're not going to have time to go looking for that, because blood collection and processing will be immediate. We can also collect and process blood postoperatively, whether it's in ortho or cardiovascular surgery. In orthopedic surgery, we are seeing that diminish because of the use of fibrinolytic agents, but orthopedic recovery rooms have a specialized vacuum regulator that has a maximum value of 80 millimeters of mercury, and it's intermittent because the wound is not vented, so you don't want to literally suck the blood right out of the patient's veins and capillaries. Now, in cardiovascular surgery, we use chest drainage kits. It is important that the chest drain that you're using has to have a specific labeling on that particular product that says it's okay for autotransfusion. And most companies do have that device. Unfortunately, it's only one. And remember, vacuum is carefully regulated. Well, not only do they have a water seal, they have a water column in them. They're attempting to maintain a negative pressure of no more than 15 to 20 millimeters of mercury. This is called the WD-20. It's a universal bifurcated wound drainage connector that connects where the suction anticoagulant line was connected to the tip, the Yankauer tip. And what we're going to do is there are 3 sizes on this tubing, and we're going to cut it. It's silicone, and we're going to plug in the tubing of the Yankauer. We don't use any sort of glue. That is not necessarily needed. And it's got 2, so we can actually use 2 different lines. Now, again, make sure that whatever you're using for post-op blood processing, it must be labeled as being approved for autotransfusion. Now, Bob Groom, my hero, and we're going to hear about it in just a few minutes, is going to talk about the use of directory infusion systems. And there, everything that comes in the reservoir goes right back to the patient, starting with the anticoagulant. They're called flip and drip by AABB. Generally, the volume capability of those technologies is 0.5 liter to 1 liter. And then the labeling will say, if you need more than this, you need to go get an autotransfusion machine. And there are significant costs and risks of using this. And unfortunately, again, if they don't have a machine and disposable, directory infusion is all that they got. Believe it or not, up to 40% of autotransfusion procedures worldwide do involve directory infusion. Now, we have surgeons who say cell savers make my patients bleed. That's absolutely false. Dr. Ernil Hansen at the University of Regensburg did a study for cancer patients where they were also irradiating the red cells. And they wanted to look at how were the cells doing. So he actually had 4 volumes and he used 4 different radioisotopes. So we had autologous prenodate from the patient. We had intraoperative cell salvage. We had hemodilution. And we had donor blood. And at the end of the procedure, they looked at what red cells had the longest survivability, were the most apparent, and had the largest mean cell volume. And lo and behold, the very best red cell in that study was the washed recovered red cell. All the neocytes and the old fragile red cells had been eliminated. So in reality, the very best red cell that can be given to a patient is a red cell that has been washed. Since 2007, STS and SCA have identified a series of modalities in the theme of perioperative blood management to conserve blood and minimize patient transfusion. In 2007, there were 21 modalities identified, 14 modalities intraoperatively and 7 preoperatively. By 2011, that list had grown to 100. And interestingly enough, one of the primary mechanisms identified, which had the highest level with the best documentation in historical practice, was autotransfusion. And not only did cell salvage maintain its 1A indication in 2007 and 2011, it's still 1A in 2021. It's important to understand, if you think you're performing blood management, you do not have an autotransfusion machine. You're not performing blood management. Also, if you only are using an autotransfusion machine and you are not implementing the other identified modalities, you are also not performing blood management. So this is critical. Now, I go into a hospital and they say, John, we want you to train everybody. Man, that's absolutely incorrect. I can train anybody on setting up a reservoir sucker line bag of anticoagulant because everybody knows how to set up a waste system. So it's an exactly similar setup, 15 minutes. I can train anybody everywhere. And that standby collection set is now even outside of OB-GYN in case you have a patient that goes in to help. And of course, if you know you have an ectopic pregnancy in the house, you better have that collection system there. Otherwise, we cannot recover blood that's on the floor. Hoover, Eureka, and Dyson are not part of product labeling. Now, the good news is in all those surgeries, we can have a device and a qualified operator standing by somewhere else in the hospital. And what we'll do is we will call for that individual in the device when we get a decent amount of blood. And remember, I said was 500 to 1,000 mLs. Even though these autotransfusion devices are highly automated, they're sophisticated, and it takes considerable training and experience. So consequently, the hospital needs to identify key super users who will be performing at least 50 procedures a year. I got news for you. There's nothing in life, much less in the hospital, that you can do once a month and be good at. I'm not crazy for tennis, but if I only played tennis once a month, oh man, they'd be kicking my butt up and down the court. So I would need, if I get a chance to play tennis, at least in my case, 3 times a week, my game's going to be a whole lot better. And by the way, as perfusionists, as you know, you have many other devices, not just the heart-lung bypass machine, but multiple blood testing and monitoring devices that you have to perform periodic competency studies. And in general, that 50 procedures a year applies to all of those devices, not just cell salvage devices. Of course, we know about Dr. Colleen Gorman Cook's paper that came out where she identified transfusion of allogeneic blood as being the primary cause of mortality and morbidity in cardiac surgery. And she noted that cardiac surgery patients who got red cells versus those who got no red cells had double the mortality rate at 5 years. Now, as you know, the International Board of Blood Management was established by AMSEC over 20 years ago. And the idea was to create online testing for operators to confirm their competency and their knowledge. It's performed about 3 times a year online with a proctor, and it does, as a minimum, require that that person has completed 50 autotransfusion procedures. Now, where does that sound familiar? You need 50 bypass procedures to maintain your annual competency. And this is totally recognized by AABB. And I'll tell you a little secret, because I am one of the original members of the International Board of Blood Management. I had a private conversation with one of the major liability insurers, and I can tell you that they were all for this 50 cases a year with both the perioperative blood management technology certification and the perioperative blood management specialty certification. That individual told me, he said, look, John, this guy was on a bicycle last week delivering pizza, and this week he's in the operating room performing a critical procedure, and they want me to cover this guy for $1 to $2 million. We're not real happy about that. So although it's not mandatory, it's absolutely coming. And for any of your operators who are doing this, it does also involve platelet sequestration and especially platelet gel practices. So they need to study those areas as well. Otherwise, they will fail the test because it's a significant amount of the content there. Well, here we are at the conclusion, and I'm pretty much on time, but you all should understand at this point, the blood supply is still critical. Autotransfusion is a truly excellent clinical practice, delivering the best red cells possible. That you now understand that you don't have to have a machine and disposables in every operating room, and that you can have one machine, one set of disposables, and one operator standing by for 6 to 8 different surgical scenarios. Well, what does that do? It's going to save you money in terms of autotransfusion. It's going to save you money in terms of disposables, and obviously it's going to save you money in the amount of super users. And you absolutely have to have enough super users to cover all 3 shifts and vacations. And that doesn't have to be a lot of folks. It can be as little as 4 and maybe no more than 8 people. So instead of having 8 autotransfusion machines in my hospital, I could probably get away with a couple. And remember, having it in that reservoir allows us the opportunity to make the decision to perform autotransfusion on that patient. And I will only train the super users, and this applies to all manufacturers. They got to be at least performing 50 procedures a year. They need to take the PBMT and PBMS tests, and I know that several perfusion schools are including that testing as part of the master's training for those perfusionists, and that's an excellent idea. Although you don't need it as a perfusionist, those are excellent credentials, especially if you're trying to get a job or if you're a service providing autotransfusion and you have certified operators and the other guys do not have certified operators. Once again, I want to thank Mohammed and Sherry for allowing me to participate, and I will be standing by throughout the rest of the scenario to answer questions. Now, I see a quick question about autologous pre-donation. I actually did that before I got involved in cell salvage. And no, You don't want to make the patient sick by dropping their hematocrit. You only get red cells, no platelets, no plasma. Their chances of being right next to the blood bank that has that pre-donate are slim and none. In fact, historically, less than half of the pre-donate was ever transfused, and they were only given red cells. And 20% of the time, the autologous pre-donate was lost in the hospital. So I can tell you, it's obviously something very near and dear to my heart. And I'll take a quick look here at the chats to see if there's anything else that I need to answer, or I will wait till later. Thank you, Sherry and Mohammed, and everybody enjoy Memorial Day. And to my fellow veterans, thank you for your service. Take care.